Rahman Rahim. Before I start, I'd like to dedicate this session actually in the honor of two pioneers in pediatric cataract surgery. The first to work in pediatric cataract in Alexandria, Professor Hussein Ali Hussein, and the first to work pediatric cataract surgery in Cairo University, Professor Mohammed Sada. Professor Hussein, I always like to find the opportunity, whenever I have the opportunity, to thank you. كل التلاميذ حضرتك along the years, and these are just some of them, all you taught them the knowledge and skills of surgery في ميزان حسنات حضرتك. All the cases you did operate along the years, طفلة, and then all the cases we operated their children برضو في ميزان حسنات حضرتك. This is a case you operated 30 years ago, and then we operated her baby. All your students working congenital cataract inside Egypt and outside Egypt, from Africa to the Far East, Indonesia, كلهم في ميزان حسنات حضرتك لأن حضرتك اللي علمتنا pediatric cataract surgery. حضرتك today طفلة حضرتك عيلة بحالها عملت لها حضرتك congenital cataract surgery 30 سنة. الطفلة دي والطفل ده وطفلة كمان. And then we operated their children for congenital cataract. الطفلة and her baby, they are coming to thank you حضرتك and to give you flowers and to tell you thank you for being with us today. And now we're going to start the session. It's intraoperative difficulties and postoperative complications of pediatric cataract surgery. We will start the first talk, iatrogenic anterior and posterior capsular tear. Anterior capsular tear due to high vitreous pressure. Whenever you open the anterior capsule like that, immediately, even before going out with the cystotome and trying to hold the anterior capsule, a tear in the anterior capsule occur and extend horizontally. Immediately stop, inject viscoelastic, ask your anesthetologist to deepen the anesthesia and give you muscle relaxant. Aspirate some cortex and then cut part of the anterior capsule, make a half-rhexis, and then the upper flap, cut it and make a half-rhexis, and still, despite of the presence of the tear, you can perform posterior rhexis and implant the IOL inside the capsular bag. Anterior capsular tear iatrogenic due to high lenticular pressure. In these cases, due to intumescent lens and the pressure inside the lens is high, once you open the anterior capsule, there is cortex that emerge into the anterior chamber, but actually there is no enlargement of the capsular tag because the lens matter is liquefied. In these cases, we go and aspirate the cortex, and then we go at the edge of the tear and aspirate some cortex, and then we can proceed with the anterior capsulorhexis in the conventional way. Iatrogenic anterior capsular tear during irrigation aspiration. Some cases of traumatic cataract, if you see here, this is a site of the plaque in the anterior capsule, and we are expecting to have a posterior capsular tear. After performing anterior capsulorhexis and during irrigation aspiration, we can see the traumatic posterior capsular tear. Here, during irrigation aspiration, this is a weak point due to penetration of the needle. It may tear up. What to do in these cases? We have to go first with vitrectomy to know the actual size of the tear, and then cut the edge of the posterior capsular tear, and we complete it into posterior rhexis, perform vitrectomy, inject viscoelastic in the bag, and then we can insert the intraocular lens inside the capsular bag despite the presence of anterior capsular tear. Some cases of congenital cataract, they have fibrosis of the anterior capsule. After cutting the anterior capsule, you can see here the junction between the fibrotic and the non-fibrotic part, usually a weak point. You should take care because during irrigation aspiration, you can see this area, weak area, it may tear up like that. And here you have an iatrogenic tear in the anterior capsulorhexis. What to do? You have to ensure that the posterior rectus is continuous in this area. Why? Because years after surgery, it will become fibrotic, a beautiful capsular ring for secondary IOL implantation in the future. Iatrogenic tear during hydrodissection. Here, after irrigation aspiration, once you have a fibrosis in the anterior capsule, you should take care. It's better not to do hydrodissection or hydrodelineation. Why? Because it tears up easily. You have here a tear. But despite the presence of the anterior capsular tear, you can still perform posterior rhexis anterior vitrectomy and implant the intraocular lens inside the capsular bag. Iatrogenic posterior capsular tear. Due to or while polishing the anterior capsule, this was a straightforward congenital cataract after anterior capsulorhexis and irrigation aspiration. And during polishing, due to high vitreous pressure, that's why anesthesia is very important. Polishing the back surface of the anterior capsule, a tear did occur. How to proceed? And then vitreous did emerge. Once it is rounded, it means that vitreous did emerge into the anterior chamber. First, do dry vitrectomy in order to know the actual extent of the tear. And then we make it circular. We go with the rhexis forceps and make it circular, and then cut the other edge and make it circular. Once we make it continuously, it will not tear up. We can inject the intraocular lens inside the capsular bag between the two rhexis. Posterior capsular tear during IOL insertion. This is a plaque. And then we made a posterior capsulorhexis in the conventional way, but due to improper folding and loading of the intraocular lens, it did tear the posterior rhexis. But when you use an ideal IOL, you can insert it inside the capsular bag despite the presence of posterior capsular tear. Posterior capsular tear due to high vitreous pressure. You have here a traumatic cataract with, here, this is a large anterior capsular defect, traumatic. First, we cut the edge and make a half rhexis by rhexis forceps. Here, the anterior capsulorhexis. And then we did irrigation aspiration. And there is another posterior capsular tear due to trauma with vitreous opacities. But due to high vitreous pressure, what happened? This tear did extend. So we have to quickly make it continuous curvilinear by the rhexis forceps, and then cut the edge, and then continue into a circular tear. Now we can proceed with anterior vitrectomy and IOL insertion inside the capsular bag. This is the last case with a huge anterior capsular tear due to trauma. After irrigation aspiration and during polishing the back surface of the anterior capsule, here there is a posterior capsular tear, and it did enlarge like this. So we are left with a huge anterior capsular tear and iatrogenic posterior capsular tear. Again, we should inject viscoelastic and stop until the vitreous pressure is low, deepen the anesthesia, and use more muscle relaxant. Then we can cut the edge of the anterior rhexis, the anterior capsule, and make half a rhexis. Cut the other edge and make half a rhexis. And then you can proceed with the posterior rhexis in the conventional way, posterior capsulorhexis, anterior vitrectomy, but take care, it should be a very good anterior vitrectomy to make the eye soft and the vitreous pressure low. So, despite having a tear, traumatic in the anterior capsule and iatrogenic in the posterior capsule, we still can inject the intraocular lens inside the capsular tear. And you can see here, this is the posterior capsular defect. So finally, to conclude, you have to be very meticulous and careful during pediatric cataract surgery. Anesthesia is very important. You should have low vitreous pressure by deep anesthesia and muscle relaxant to perform a safe and sound surgery. And thank you very much for your kind attention.